So the next two speakers in quick succession, I can think of three power couples in the world on the top of my head. I can think of Gianni and Marella Agnelli, the head of Fiat, and one of the greatest and most fashionable businessmen that Europe has ever seen. I can think of Marie and Pierre Curie, the Nobel laureates who worked on radioactivity. And I can think of Ugur and Özlem, who founded BioNTech, and they went on to develop a vaccine for COVID. And when it comes to our own speciality, like all academicians, they always feel it shouldn't be movie stars and singers who should be asked as to what should be done to handle the world issues. Academics should be asked that question. And if, as far as academics go, I think Professor Rafeal and Dr. Mario represent the power couple in liver disease and in hepatology on planet Earth, bar no competition. Professor Rafeal he's been introduced before, but once again, since you're also sleepy, it's siesta time for everybody. He's the head of internal medicine and hepatology at the liver unit of the Hospital University of Val d'Hebron. That's the Hebron Valley for those who don't understand Spanish. He's a member of the AASLD, and he is the president of the Spanish Association for the Study of Liver Disease. Most importantly, for all you young lot out there, he's written more than 350 papers, all published in peer-reviewed journals. So take some stimulus from that. He shall be speaking on diagnosis and long-term management of chronic HBV. And everybody would be asking the question, how long do you want to continue your nucleoside or nucleotide analogs? So let's hope we are much the wiser by the end of these 20 minutes. Professor Rafeal.
Thank you very much for this introduction. So siesta has finished. Let's move now to hepatitis B. And I would like to show you which are the benefits, longer-term benefits of treatment of this disease. This is the patient case. He was a 51 years male, diagnosed of HBV in 2006. There was not a clear risk factor for the transmission. ALT was 111 international units. E antigen was negative. HBV DNA was high, 350,000 international units. And the liver biopsy at that time showed a nodal score of 12 with F4, and the METAVIR was A2F4. Platelets were 155. The endoscopy, the gastroscopy was normal. There were no esophageal varices. The ultrasound was normal. In fact, there was not any lesion of HCC. The liver stiffness was high, 17.8 kilopascals. There was no comorbidity. The eGFR was normal, and serum phosphate was a little bit lower, 0.58 millimoles, but not very, very low. In March 2016, the patient started tenofovir. And I have a question for you. Which is the risk of HCC under treatment at 5 years in this patient? Low, medium, or high? Those who think the risk is low, raise hands. Those who think This is medium. And those who think this is high. Okay. So there is a diversity of opinions. Good. But everybody accepts that there is a risk. So this is the point. There is a PHB validated in Europe, and this is a multi-center. You can see here the name of the main hepatologist in Europe, conducted by George Papatheodoridis in Greece. And this score was validated, and they take into account age of the patient, gender, and platelets. And you can observe, depending on the age, on the gender, and the level of platelets, they give points. That means with a score over 15, you have a very high risk of developing liver cancer. So in fact, if you make a picture of the ideal patient to develop liver cancer, should be a male over 60 with low level, with less than 100,000 platelets. In fact, that translates that a cirrhotic patient at diagnosis has a very high risk of developing liver cancer. Okay, the patient started tenofovir in March 2016, and you can observe in 2017, so after 1 year of treatment, ALT decreased to 55. HBV DNA went from 20,000 to less than 400 international units. No, these were, I'm sorry, copies per ml. But anyway, there was an important decrease in the concentration of HBV DNA. The GFR was maintained. The phosphate, again, was normal. Platelets increased a little from 155 to 170. The elastography showed 9.1 kilopascals, and the ultrasound was normal. So these are the Israel recommendations in 2017. At baseline, kidney function test, eGFR, and serum phosphate levels should be performed in patients taking nucleoside analogs. Patients at risk of renal disease treated with any nucleoside, and all patients regardless of renal risk treated with tenofovir should undergo periodical renal monitoring, including eGFR and serum phosphate levels. The frequency of renal monitoring can be every 3 months during the first year and every 6 months thereafter. I very frankly, nobody does it. So we check the renal function baseline, and if there are no risk factors for renal insufficiency, we follow on treatment without any other special control. But there are renal abnormalities. This is a survey on 260 treatment-naive patients with chronic HBV infection, and you can observe 38% presented proteinuria, abnormal urinary sediment roughly 20%, hypophosphatemia 10%, vitamin D level less than 20 milligrams per liter, 64%, and 36% of patients presented stage 1 renal insufficiency. This is not a real clinical problem, but should be monitored. So, how would you interpret the decrease of liver stiffness from 17 to 9? And this is an important question, because it's dangerous to use elastography to monitor patients under treatment, because you may be wrong. You can tell the patient you are okay, you have no disease, this is a real improvement, but let me tell you, in part, the decrease is due to the decrease of inflammation. And this is not a useful system to monitor patients under treatment. But the liver biopsy is, and this is still the gold standard for those patients. And this patient presented in 2016 a nodal score of 12, an HBV fibrosis score of 6. 1 year later, under treatment, the nodal decreased to 7, and the HBV fibrosis score to 3. And this is a real issue. This is not imagination. This is a real improvement of the liver histology. So because some people say these treatments are cosmetic treatments because you don't be able to clear HBsAg, and it does not produce any improvement in the liver disease. I am showing you that this is not true. This is not a cosmetic treatment. There is a real improvement in the liver histology. So the question now is, when you stop HCC screening, given that there is an improvement in the histology? Paul Kuo says no. Yes. You stop treatment? Okay. So there is an agreement to continue on surveillance for HCC, okay? I agree. Okay, the patient, you can observe here the progression, 2018, 19, 2020, 2021. The ALT were normal. The HBV DNA was negative over time. He maintained the GFR normal. The phosphate was normal. Platelets were between 190, 199. The elastography, you can observe, improved from 8 to 5.7 between 2018 and 2021, and the ultrasound was normal. So again, let's see. There was a biopsy after 5 years of treatment, and observe the nodal score was 2 and the HBV fibrosis score was 2, coming from 12 and 6. So there is a real improvement in the histology of this patient. And we have learned that cirrhosis is not an irreversible disease. There are different stages of the liver cirrhosis, and cirrhosis may go ahead or go down depending on different factors. And therapy is the most important. And you can observe in the study of the tenofovir, many patients presented an improvement in the liver cirrhosis. So, again, this is a very important feature. So, would you stop HCC screening now? Because the patient looks, he has not liver cirrhosis, apparently. Would you stop? Paul Kuo say no. Okay, no. I agree. Which is the risk of HCC after 5 years of entecavir or tenofovir in Caucasian patients? There is still a risk. There is a risk of HCC even with the improvement in histology, the improvement in liver functional tests. So the surveillance of HCC should be maintained even in those patients. The other question is, would you stop tenofovir at that time after some years being HBV DNA negative? Paul probably will say no. Maria probably will say yes. So we will have a debate after that. So an interesting debate. But my personal feeling is not suppress treatment in a cirrhotic patient. This is the famous paper from Thomas Berg showing that some patients, E-negative patients, non-cirrhotic patients, when you stop therapy, some of them clear HBsAg. And in fact, this was not original because Stefanos Hazidianis was the first who showed that some patients may clear the antigen, the HBsAg, after stopping therapy. So the patient still treated with tenofovir and screened for HCC by ultrasound, and you can observe that he continued to be with normal ALT, negative HBV DNA, normal GFR, a low titer of HBsAg, 900 units, which is good. And then in the debate, probably we will hear that some patients with very low titers of HBsAg are the candidates to stop therapy. The patient asks you if it is possible to accelerate the HBs clearance. And this is a usual question from patients. So, okay, I am very well, but I continues to be HBsAg positive, so I have an active infection. I have not a functional cure. Can I do anything else? So the answer is that in some cases, the addition of PEG interferon to the nucleoside analog may increase the HBsAg clearance. This is not very important. It is roughly a 10% patients, but this is something that can be in mind in special patients. Patients who desire to clear the virus more rapidly. So I will stop here. There are upcoming strategies for HBV cure. Many investigators are very optimistic. I'm not. I think that we will have a long way to go before having medicines to treat, so to obtain a functional cure of the HBV infection. Thank you very much for your attention.
Thank you, Professor Rafeal. Sometimes evil doesn't come alone, and evil has a partner. Hep B has an evil partner too, and that is Hep D. And I'm sure some of you might have seen the marginally interesting, I'm not a big Marvel fan, but still, Thor Love and Thunder, and the bad guy actually needed two weapons, Thor's Stormbreaker and Jane's Mjolnir, to kill him. That was just about the only interesting part of an otherwise boring film. But there you have it. And I think Professor Rafeal and Professor Maria make the perfect team. And to counter Hep D, which is something that requires regular updates, it isn't as straightforward as managing Hep B and C, as you might see. It is absolutely essential that these meetings and these conferences continue to provide you the most up-to-date material so that you would know what is actually happening and what new tools and instruments you might have available to you. Professor Maria is a professor of medicine and chief of internal medicine and hepatology at the University of Valldebron, Barcelona. She has more than 3 decades of experience in managing hepatitis, and again authored over 300 peer-reviewed papers. And she has been the president of the Spanish Association for the Study of Liver Disease, and she is also an active member of EASL and AASLD. And now, as the last talk of the session, I shall be inviting Dr. Maria to come and speak on the management of HDV in a case in 2022.
Good afternoon. Many thanks for your kind words, and thank you again for having us in this important meeting. I would like to discuss hepatitis delta from the European perspective, because in Europe, currently, we have new tools for treatment of patients with chronic hepatitis delta. And because this is a clinical case session, I will present a clinical case of a patient, 45 years old, Caucasian man, and without a relevant history, no alcohol, no obesity, and he was diagnosed 7 years ago of liver cirrhosis. Liver cirrhosis associated to hepatitis B and D, and for this reason, he received treatment with interferon, 12 months with interferon without any type of virological response. Because he has also B, he also was in treatment with entecavir. And the lab tests show low platelet levels, elevated ALT levels, HBs antigen positive, E negative. Usually hepatitis delta occurs in E negative patients, and there is inhibition of hepatitis D over hepatitis B. Because he's receiving entecavir, HBV DNA was undetectable, and of course, hepatitis delta viremia was detectable, and around 400,000 international units. So the majority of patients know very well hepatitis B, or at least know the letter of B, but usually the first notice on hepatitis D was at the time of diagnosis. And the first question that the patient asks to physicians is, I am at a high risk of developing complications, so I have the same risk that a patient with B, or because I have both virus, I have a greater risk of developing complications. And this is a review that shows clearly that patients with hepatitis D have a higher risk of disease progression than patients with chronic hepatitis B. The risk of developing cirrhosis is 2-3 times higher, hepatocellular carcinoma between 3 and 6 times higher. The need of liver transplantation is also double, as well as the possibilities of liver decompensation and the die of liver-related causes. There is also 2 systematic reviewers that look at the risk of liver cancer in patients with Delta. And in this, one of them is a large systematic reviewer, including a large number of patients with hepatitis B and Delta, and the study shows that the risk of developing HCC in patients with Delta is higher. And what is important is that this risk is higher in patients co-infected with hepatitis C, and there is no difference in the risk between patients with or without cirrhosis. Our patient has a detectable viremia, and this is also a factor important in the risk of developing complications. So probably the question is, which factors are associated with development of complications? The presence of cirrhosis? Of course, yes. What about persistence of HBV RNA, HDV RNA, or non-response to interferon, like our patient? And this is a study performed in Italy by the group of Massimo Colombo, by Romeo, as showing in a large number of patients with hepatitis Delta followed for a mean of 20 years that the risk of the factors associated with risk of developing cirrhosis, decompensation, and hepatocellular carcinoma are persistent viremia, male gender, cirrhosis at the time of diagnosis, and the lack of antiviral therapy. On the other hand, there are several studies looking at the efficacy of interferon in patients with Delta and also the clinical impact of this treatment. And these two studies clearly shows that patients who respond to interferon therapy, that means achieve undetectable viremia, the risk of developing complications and the risk of having a liver transplantation or liver-related mortality is lower in those with interferon response than in non-responders. So, in our patient, what are the therapeutic options if there is an interferon non-responder? In some countries, the only therapeutic option is interferon for longer duration. Nucleoside analogs are not effective for Delta, are very effective for B, but not for Delta. And there is a new drug that is available in Europe that is called bulevirtide. So retreating the patient with interferon and with a longer treatment duration instead of 48 weeks, 2 years, it's associated with a similar response than treatment for 48 weeks. There is not an increase in virological response, and for this reason, the guidelines, the EASL guidelines and the American guidelines recommends as a treatment PEG interferon, at least for 48 weeks, is the treatment of choice for patients with compensated liver disease. The recommendation is similar for both guidelines. In patients with hepatitis B replication, nucleoside analog therapy should be considered and should be added. But 2 years ago in Europe, the European medicine agencies got the conditional approval for a new drug that is called bulevirtide, that is a first-in-class entry inhibitor that blocks the viral entry receptor for both, for hepatitis B and hepatitis D. And this drug, it's a drug that is administered subcutaneously, and it's indicated for patients with chronic hepatitis Delta with HDV RNA positive and compensated liver disease. The dose recommended is 2 milligrams. This dose was based in phase 2 clinical trials. This is very unusual because usually all the drugs were approved after a phase 3 clinical trial. And this drug was approved in Europe only having data on phase 2 studies. And why? because the prognosis of Delta, as I showed before, it's worse, it's bad, and there is no, at that time, available medication useful for this disease. Here you have the data of the phase 2 studies that got the approval, the conditional approval of this drug, and with the dose of 2 or 10 milligrams, approximately 53-71% achieved viral response, that is defined by 2-log decline in the levels of viremia or undetectable viremia. But what is more important is the combined response, that is the virological response plus normal ALT levels. And these results now are completely reproducible in the phase 3, ongoing phase 3 study that evaluates the efficacy of bulevirtide 2 or 10 milligrams in patients with hepatitis D. After this conditional approval in Europe, we started to use this drug in the real world. And this is the experience of the French groups and Italian groups using the recommended dose, 2 milligrams of bulevirtide, and it's very similar to those observed in the phase 2 studies and in the ongoing phase 3 study, showing that bulevirtide 2 milligrams in real world achieve virological response and decline in the levels of viremia. This drug has also been combined with pegylated interferon, and these are not head-to-head studies, but combined with PEG interferon plus bulevirtide, there is an increase in virological response. It's a subcutaneous drug like interferon that needs to be administered every day, but the safety profile is excellent. There is, as a main adverse event, an increase in the bile acid, but without any clinical consequences. So this drug has been used in patients with advanced cirrhosis, but compensated but with portal hypertension, and this is some few reports of clinical cases that has been treated with this drug, not for 24 or 48 weeks, over 3 years of treatment. And we can see here in a patient number 1 that when we stop the drug after almost 1 year and a half of treatment, there is a relapse, suggesting and showing that we need with this drug long-term treatment. And in patient number 2, this drug has been administered for almost 3 years, and he persists with the virological response, and also he has a significant improvement in portal hypertension. And these are new data published in Journal of Hepatology, in the last number of Journal of Hepatology, in 18 patients with cirrhosis and significant portal hypertension treated with bulevirtide monotherapy for 48 weeks. And you can see a decline in the levels of viremia and improvement in ALT levels. Approximately 23% of them achieve undetectable viremia, 83 biochemical response, and what is more important, there is improvement in portal hypertension in all the cases. So let's go to our clinical case. The patient, it was 5 years ago. At that time, the only drug available was interferon. The patient developed all the liver complications typically associated with hepatitis D. Clinical significant portal hypertension, esophageal varices, ascites, and also for this reason was referred to our liver transplant center. And at that time in the examination, we also were able to see in the MRI a small hepatocellular carcinoma. And for the reason, he was evaluated, and at the end he was admitted for a liver transplantation, at that time with undetectable viremia for B, but detectable for Delta, and we performed liver transplantation. The liver transplant was perfect, and now the question is, having a patient with hepatitis B and Delta, what is the recommended prophylaxis to prevent reinfection? Here we have several options: HB and NUCs, like hepatitis B, only HB, or a short course of HB plus NUCs and after only NUCs, and this is done in the majority of centers after liver transplant for patients with B with undetectable viremia at the time of liver transplantation, or no prophylaxis. So we know that patients transplanted for hepatitis Delta, particularly those with decompensated cirrhosis, had a better patient and graft survival than patients with decompensated cirrhosis only associated with hepatitis B, but there is no difference in the patient and graft survival if the reason of liver transplantation is hepatocellular carcinoma. And this has been shown in another study showing the survival of patients with B and Delta is very, very similar. So what about the prophylaxis after liver transplantation? Is very similar for both associations. Is the combination of HB plus NUCs. This is the most effective strategy. And the guidelines for hepatitis B don't pay attention to Delta, and there is no special recommendation for those patients transplanted for Delta. But now we have a position statement and recommendations of the European Association called ELITA, and in this the recommendation for low-risk patients with undetectable viremia, hepatitis B DNA undetectable at the time of liver transplantation, it's HB plus nucleoside analogs, short course, or nucleoside analogs alone. For those with high risk, that means detectable viremia at the time of liver transplantation, the recommendation is combination of both, and hepatitis Delta is considered a special population. And that means that the recommendation is to use nucleoside analogs plus HB lifelong and explore the possibility of a shorter course of HB in clinical trials. So in summary, my take-home message in management in patients with hepatitis D and liver cirrhosis is that these patients have a higher risk of disease progression, decompensation, and hepatocellular carcinoma than those monoinfected with B. And particularly, this risk is higher in those with persistent delta viremia. Interferon or bulevirtide therapy, even in patients with cirrhosis, can induce virological response, which is associated with less liver-related outcomes and a better prognosis. Liver transplantation is the gold standard approach for patients with Delta, with end-stage liver disease and hepatocellular carcinoma. Prophylaxis against hepatitis B recurrence after liver transplantation should be based on patient individual risk and a detailed cost-effective analysis. And finally, combination of nucleoside analogs and HB remains the gold standard for the prophylaxis against hepatitis B recurrence, and HB withdrawal can be considered in the setting of clinical trials. Thank you very much.
Thank you, Professor Maria. Just before concluding the session, I would like to ask the honorable chairs for their comments on the talks. Any observations?
Professor Anwar, I would like you to sum up on behalf of all the chairpersons. Thank you.
Thank you very much for a very nice session. Very important topics were discussed, and we all learned from these topics. And it just remains for me to thank the speakers who have elaborated the subjects to the best of the current standards, and we appreciate and thank you very much.
Thank you. Exactly. Since we're pushed for time, we will be moving immediately to the next session. 2 state-of-the-art lectures. I would like to invite the moderator, Dr. Omar Farooq, to kindly start the proceedings for the next session.